Didn't realize how big this was. My name is Whitney. I'm originally from Monroe, Louisiana, and currently a PGY1 resident at St. Dominic, right on the road. So we currently in our unit have a 54-year-old African-American male who was admitted to us via ambulance with really sudden onset chest pain at work. He works at the chicken plant as a butcher, and coworkers had noticed him down, slumped over, complaining of pain, chest pain, and called the ambulance. In the ambulance, he was noted having a blood pressure of 250 over 120, and upon clinical recheck at St. Dominic's ER was 240 over 120. At that point, he was denying any shortness of breath, nausea, vomiting, any stroke-like symptoms. He does have a history of a left basal with ganglion bleed, with mild right-sided weakness, hypertension, and morbid obesity. After talking to his wife about his med rec, she did say that he did have his medications, but about a month ago he ran out due to his work schedule and unable to reschedule a doctor's appointment to get refills. So uncontrolled hypertension, we actually checked and they were last filled in June, so that's a long time to be out of them. The patient was unable to provide really any other information regarding his last dose, so we knew it had to be a long time in the past. An emergent CT was performed of his abdomen and pelvis, showing an extensive aortic dissection that began at the descending thoracic aorta distal to the origin of the left labial artery and extended down through the descending thoracic aorta into the left common iliac artery. So a very large dissection. He was then diagnosed with type B dissection and started on PharmD and had small infusion in the emergency room, and CT surgery was consulted to assist with management. He's currently still in the unit and went for a lumbar drain today and is awaiting T-bar. So aortic dissection, an acute aortic dissection, the general population is estimated to range anywhere from 2.6 cases to 3.5 per 100,000 persons, and usually tends to be in males between the ages of 60 and 80. And if left untreated, around 33% of patients will die within the first 24 hours, and 50% within the first 48 if they're untreated. The 2-week mortality rate for these patients is 75% with an undiagnosed ascending thoracic infection. So if tear is actually occurs in your aorta, and as the tear begins to move, it extends along the wall of the aorta, you'll actually get blood flow that will then pool into the layers between the vessel and form what we call false lumen. Common risk factors, of course, are aging, atherosclerosis, blood trauma to the chest, and high blood pressure, which in his case is definitely the case. It's uncontrolled high blood pressure. Just so if you ever see on a CT, I'm still new to this, so looking at them, I want to see the difference between type A and B. So type A is going to be within our ascending aorta with or without any involvement of the transverse or descending thoracic aorta. And type B, which is what this patient is, originates in the descending and the thoraco-abdominal aorta, regardless of any retrograde involvement in the heart itself. Type A needs emergent surgery, and type B you can manage aggressively with blood control, rate control medications, which in his case got to the unit and we were trying to just keep him at a stable blood pressure before we actually do surgery on him, just to make sure he is doing an adequately stable blood pressure is. So the treatment, according to the guidelines, first we want to definitely use beta blockers with our systolic goal being 100 to 120 and a heart rate goal of less than 60 per minute. Usually we start out with IV propranolol, metoprolol, labetalol, or esmolol. In this patient, I did read back in his history, and he did say someone along the way told him he had COPD or maybe some type of asthma-related issue. So we did actually start esmolol with this patient. So there's patients with a bronchial asthma status, bradycardia, or any sign of heart failure. You want to use or try esmolol first, do a short half-life to kind of see how they're going to respond to it, and then we can maybe get another agent to tolerate. Also, we can do calcium channel blockers if they can't tolerate a beta blocker or it's maybe not working as effectively, especially for rate control. Our non-DHT or norepinephrine will tie them, and if you have to do the DHT, nicardine, which was on board. If your systolic blood pressure does remain above 120 after adequate heart rate control, you can further use an ACE inhibitor or vasodilator to reduce blood pressure further. Those that are thought to be better will be sodium nitroprusside, nitroglycerin, and phenolphthalein. These should not be initiated first due to reflex tachycardia if there's any increased tiered in the tier pressure on the order. So first you want to start our beta blockers, and then you go to nitroglycerin or whatever agent you choose out of our big palette. So definitely doesn't occur as often as diabetes, but it was nice to have one and actually get to see it. You'll have these questions. I'll take those. Enjoy your big one.